underway. Hello, everybody. Welcome, welcome. Please find a seat. Thank you for being here. I'm Judy Woodruff of the PBS NewsHour, and I am just delighted to welcome all of you to a session that the Ideas Festival Spotlight Health is calling a deep dive. And I consider it just a really extraordinary opportunity to hear from 5 people who oversaw the government department charged with overseeing health care and at one point education, as well as welfare. But since 1980, as everybody knows, Health and Human Services charged with overseeing health care and welfare, which what the government renamed Human Services. We think this is a first of its kind coming together of these 5 former secretaries. They each served they served 5 different presidents, both political parties, spanning a 40-year period from 1975 until 2014. We're going to use this occasion to talk about health care in America today, to talk about Medicare, to talk about Medicaid, both of which this year, as you know, celebrate their 50th anniversary. Just a quick reminder before I introduce them of what has happened over the course of that 40 years. In 1975, the population of the United States was 215 million. Today, it's 320 million. In 1975, Medicare and Medicaid were only 10 years old. In 1975, we think the budget of the department was around $300 million, and according to Secretary Mathews, that was more than the budgets of every country on the planet except for the United States and the then Soviet Union. Today, guess what the budget of the Department of Health and Human Services is? It's just exceeded $1 trillion. So a lot has happened, 90,000 employees today, is that right, Kathleen? So a lot to talk about, a lot of changes, and let's get underway, and I'm going to quickly introduce them. Starting from your right, David Mathews, appointed by President Gerald Ford started serving in 1975. He served through 1977. Since 1980, you should know, he has been the president of the Kettering Foundation, a nonprofit research foundation that studies democracy. Dr. Louis Sullivan, who was appointed by President George H.W. Bush. Dr. Sullivan served as secretary from 1989 to 1993. He now chairs the National Health Museum. He has been the dean of Morehouse College Medical School and many other accolades and positions of responsibility. Donna Shalala, appointed by President Bill Clinton. She served as secretary from 1993 to 2000. Since then, she's been president of the University of Miami and just recently named president of the Clinton Foundation. Tommy Thompson, appointed by President George W. Bush. He served from 2001 until 2005. He had previously served as the governor of the state of Wisconsin from 1987 to 2001, I believe the longest serving governor ever of that state. Most recently, he served as an attorney and as a chairman of the Deloitte Center for Health Solutions. And last, on your left, Kathleen Sebelius, appointed by President Obama. She served as secretary from 2009 to 2014. As such, she oversaw the implementation, the lobbying for, the passage of, and the implementation of the Affordable Care Act. And as everyone knows, she previously served as the governor of the state of Kansas from 2003 to 2009. So let's give them all a warm welcome. I'm going to start out with a very easy question. What do you think of the Supreme Court decision on Thursday announced on the Affordable Care Act? David Mathews.
Well, I think we've finally gotten the wrangle over and we can settle down to actually implementing the act. It's great. We want everybody in the country to have insurance. They should have it. But having insurance doesn't necessarily mean that you're going to have health care. And the next challenges are going to be in providing the health care for a much enlarged population.
I second that. I'm quite enthusiastic about that because you really can't have a wealthy nation if your people are not healthy. And this bill really provides access to care and it will also give people the opportunity to use the health system in a wiser way than we have been. We are used to emergency care, crisis care. We need to have our citizens using the healthcare system in a logical, proactive way, combining that with improving our healthy lifestyles. And if we do that, then indeed we'll be much healthier 10, 20 years from now than we are today.
Donna Shalala.
Well, I think I'd start out by saying, wow. The bill was passed by one party, but the significance here is that appointees of both political parties upheld it. And it was a solid decision. It's really extraordinary, but my feeling, like my colleagues, is the work has just begun. We've settled the issue of whether we can cover large numbers of working folks with a new plan, but now we have to make sure that we make adjustments in it so that people really get health care, not just insurance.
Tommy Thompson.
Well, I'm not crazy about the decision, but saying that, let me qualify that by saying it gives us the opportunity now to come together. It stabilizes healthcare, it stabilizes the law. The ACO now is the law of the land. Now we, all of us collectively, Democrats and Republicans, have got to refine it, make it better, make it work. And it's not going to be changed dramatically or repealed, but there's many areas that can be improved upon, and that's what my goal is to do everything I possibly can to improve the law and make it the best that it possibly can, so people, as everybody has indicated, are able to be covered by health insurance and health coverage in America.
Kathleen Sebelius.
I didn't know there was a decision on Thursday. Clearly, I'm pleased with the strong majority of the court. I'm pleased that the chief found the strongest possible argument. He didn't defer to the IRS, to the agency, which was one of the possibilities, just saying this IRS decided one way, which would have left, I think, the interpretation then open to a new administration to overturn that. He found that the basis of the law stands and that the subsidies stand. And so it means that 6.4 million people in 34 states in the country continue to have the coverage, that the markets will continue in a competitive way, and that the progress that has been made can go forward. And hopefully we can stop relitigating the past and actually talk about the future.
All right, I don't want to spend a lot of time on the ACA, but it is very much present in everyone's mind right now. What is working well with the ACA and what isn't working? Tommy Thompson, you were the one person on the panel who said you really want to work hard to fix it. What do you want to fix?
Well, first off, I want to make sure that we're making sure that the states are going to be able to use the Medicaid coverage and get as many poor people involved and be able to be covered. Secondly, I think the insurance provisions everybody agreed upon, Republicans and Democrats, in regards to raising the limit and also taking off the limit so insurance companies could not in any way disinsure individuals. There are a lot of good parts of it that need to be built upon. In regards to the overall ACA, I think there's many ways to bring cost efficiencies in. And I think now we have to realize as a society that Medicare and Medicaid are very expensive. Medicare is going broke. We have to now use this law to make sure that Medicare becomes more efficient and we take out a lot of the extra costs, a lot of duplication. Rules, regulations are one. Fraud and abuse is a second one. Third one, of course, is still using so much paper in clinics and hospitals. We can improve all of those and save lots of money and be able to expand healthcare tremendously in America.
Why don't those changes need to be made that he cited initially, Kathleen Sebelius, Medicaid provisions in the states having to do with insurance premium?
Well, we have now governors some of whom have chosen not to take advantage of the Medicaid expansion in the state of Wisconsin and in the state of Kansas. We both have sitting governors who have said no to what is probably the single most generous cost sharing that has ever been put forward. Governor Thompson and I both talked about the fact that if we had been governors and been given this deal, it would have taken about 35 seconds to say thank you very much. 15. I would have taken 35. I would have thought. So, I mean, that's really a state-based decision. I think Governor Thompson talked about the electronic records replacing paper files, and that's very much underway. We started in 2008, 20% of hospitals and only about 10% of doctors used any kind of electronic record, still exchanging information in paper files. That's now about 90% of hospitals and about 80% of docs. That's a big move forward, and it's a big platform to begin to measure and look at delivery system reform. You couldn't do that before.
How do you see this, David Mathews, when you hear Governor Thompson say these are the things that need to be fixed and they need to be fixed urgently? What do you think?
Well, as I said initially, what I'm concerned about is a very large influx of new patients, all proper, and a system that I think is not designed to deal with that population. Our system is designed to deal with very serious specialty problems. The largest portion of our docs are specialists. We have fewer primary care physicians. We are getting more primary care providers who are not necessarily physicians. That's good. But I'm particularly concerned about rural areas, about the poor areas in the city. Healthcare there is not good, and people are not trained to practice medicine if you practice medicine in the old-fashioned way, and Lou Sullivan showed up every day, Dr. Kildare, and made house calls, you know, he'd be dead within a week. That's just too much. That's too much to ask. Also, healthcare is not simply a matter of medicine. There are all other kind of folks that need to be enlisted in that, from social work to education. It's a system, and we really yet to train people to work in that system, particularly to use the health resources in a community.
Dr. Sullivan, what is it about this, and again, we're not going to spend much more time on this, but what is it about this law in your mind that needs to be fixed?
Well, there are a number of things, but I would start with increasing funding to improve the health literacy of our population. Because what has to happen is people have to know how to use the healthcare system. One of the things that are the cost drivers now is people are used to going to the emergency room, delaying until they they can't stand it anymore, but then don't have follow-up. What we need is to do, particularly with people who are newly insured, making sure they know what their benefits are, making sure they have a primary care provider, making sure they get vaccinations for their children, et cetera. In other words, becoming proactive. We've had a system that has been authoritarian, doing what the doctor says and deciding that's all that's needed. That's 20th century. The 21st century is having our citizens knowing that they should go in for their checkup, their diabetes should be evaluated, et cetera. So we really need to have people who are more proactive. So that's what I mean when we say we need to have a more health literate population, because if we don't change the way we use the system, we're going to continue to have an expensive, inefficient, less effective system.
Donna Shalala, pick up on that, because you know, the law does affect and change some of our health care delivery.
Well, it
insurance,
changes
but it doesn't affect everything.
Yeah, I think it changes it dramatically. It allows this new population to have free prevention benefits. They can go and have a physical exam. It extends to 26, the coverage of young people. How many people here are covering their kids now because we extended to 26? I mean, there are a lot of young people now that are getting coverage under their parents' plans. But in terms of what needs to be fixed, they had a whole set of technical corrections, but they're still going to struggle with access issues, with what happens if someone's income changes. simplification, 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 and it's got to be a combination of the government and the insurance companies. When people first signed up for their insurance, the insurance companies handed them a list of doctors. They started calling through the list, and some of those doctors said, no, we don't take Obamacare. Well, they had to the insurance companies themselves had to straighten that out. So we don't know completely now, but trying to be nimble enough to make those corrections as we go along, that'll require some bipartisan agreement. But I'm particularly concerned about the subsidies and about people whose income changes, the ability of the IRS to handle some of that. But the insurance companies need to step up as well, because they're going to have a lot of the information, but they're going to have to provide access. They're going to have to make sure that if they're playing this in this arena, that when they give someone a list of doctors they can get access to, those doctors are there. And some of it's government's responsibility, but some of it's the private sector. But there are all sorts of reforms in this that are way beyond the insurance, and Kathleen can talk about them better than the rest of us. But we're going to be learning every year and making adjustments every year. That's what we ought to be doing in the healthcare system.
A lot of conversation about whether this has any effect or much effect at all on the cost of health care. What is Kathleen Sebelius, what is health care now? What percentage? 1/6 of our entire federal gross domestic product?
GDP. Yeah.
So does this law have an effect on that? And if it doesn't, to an appreciable degree, what is going to bring the cost of health care down in this country?
Well, I think that there's some economic evidence that over the last 5 years, since 2010, health inflation in this country has been the lowest it's been in 50 years. 50 years. Still too high. We still pay more than any nation on earth, and we still have, frankly, mediocre health results. That's the troubling. It isn't that we're paying a lot more money and our citizens are living longer and healthier than anybody on earth. We're paying a lot more money and our citizens are living sicker and dying younger than lots of other countries around the world, and that has to change. Some of that is better population health. Some of it is better care, the right care at the right time, doing the right thing. And some of it really involves, I think, using the government payment system. The government right now, through Medicare and Medicaid, spends about 1/3 of the healthcare dollars that are spent in this country. Shifting that payment system to a value-based payment, smarter buying, looking at outcomes, paying for results, as opposed to volume. The more tests you do, the more you get paid. The more tests you run, the more days in the hospital, the more you get paid. Those days are coming to an end, and I think that's going to be very good news.
Why can't that happen faster? Why can't any of you come in,
Payment
Dr.
systems
Sullivan?
are slow to change, but this act actually forces some of the changes to take place. I'd add to it that we're going to integrate nurses, physicians' assistants. We're going to use the other parts of the healthcare system much more effectively. You can see the states as they're expanding the scope of practice. That is what nurses can do in this country. A number of states have started to expand that because a lot of the primary care, the end-of-life care, the chronic care management can be handled by nurses. And most of us believe that the most successful practices in the country and health systems are going to integrate that in a much more thoughtful way, giving these nurses who are trained up here far more responsibility in the system. And that will help not simply to bring healthcare costs, but to integrate the healthcare system much more smoothly for the patient.
Dave Mathews and Dr. Sullivan, why isn't some of this happening faster?
Well, I think we're overlooking something. We're talking about the healthcare system as though it were something that we could push at one level and it would change. It's a seesaw. If we push down on it in one end, the other end's going to go up. They're going to be difficult trade-offs to make. Some of you've seen, we do briefing books for citizens at our place. And there's one on what it would take to make Medicare and Medicaid affordable. For example, the thing that we could do is that we could go in to curb the cost and we could raise the age at which you're eligible for these programs, right? But that's going to leave people uninsured for a longer period of time. So there's a trade-off. Or if you don't like that, we could...
I mean, we've already raised the age.
Yeah, some, but we can raise it more. We can raise it more, and that will very significantly reduce the cost. But there's a downside. This is my seesaw principle. Or, for example, we can have doctors order fewer tests, but they're going to miss more diseases. All right, do you really want to do that? Or no, we don't. We want to get serious about prevention. All right, that's fine. We should do that, but maybe we ought to actually have some penalties. If you insist on smoking, should we really insure you at the same rate? Should we begin to make, could we make, some rules about what you eat, Well, the downside is you're going to interfere with individual rights.
I'd like to
So
say
this
that
is
for a
a-
Republican.
So there are trade-offs. So,
There are trade-offs. There are trade-offs.
and Dr. Sullivan, how do we know what the trade-offs are going to be? I mean, the
Well-
political system has been very slow to address some of these tough problems you all are describing.
Well, I come back to one of the things Dave said, and also what I said earlier. We need to emphasize much more prevention and healthy lifestyles. We have brought tobacco use down from 47% of Americans smoked when the Surgeon General first reported in 1964 that this was associated with lung cancer and now many other diseases. It's now less than 20%. But now with all of the information we know about all of the diseases that smoking enhances, why do we have any people who smoke at all? So that's what I mean when I say we need to improve our health behavior. We have a rising problem of obesity in our country, more obesity than we've ever had. Well, that's not a medical problem, that's a behavioral problem. So we need to not only fix the health system, we need to improve the health behavior of our population. We need to focus more on healthy lifestyles and preventing disease and injury, as well as making sure people know how to use this health system in an effective way.
But this is a political issue. I mean, there's a stakeholder for each of these decisions, and there are people that make money out of the way the health system is currently organized. So what you're talking about is people making less money in how the system is currently organized. So your ability to balance the interests of an industry and the interests of the American people is a political process that we just saw the ACA go through, but it's not so easy to announce that we're going to reduce the number of procedures, that we're going to pay less for certain kinds of procedures, that we want to average it out, because we're going to gore someone's ox in the process, and we're going to get pushback from interest groups and from a wide variety of people that actually, whether they like the system or not, they're making a lot of money over the way the system is currently organized.
Donna, politics is part of it, but that's not the whole thing. We need to have an educated citizenry.
Well, I
The
agree with
reason
that.
we
I
have
absolutely
less
agree with that.
smoking is because people now know about the effects of tobacco and all of the publicity around that. The tobacco companies are still just as active as they have ever been, spending as much money as they've ever had, but the number of people smoking is less than half that the number in 1964.
And obesity is starting to come down as we work on that issue, particularly in relationship to children. And you saw the McDonald's report recently, these arrangements, the Clinton Foundation actually did some of them, with some of the food companies to get them to stop pushing sodas instead of milk. All of these are beginning to have an effect. I agree about the behavioral issues, but I don't think you can run away from the overall politics here.
Tommy Thompson.
It's not just the government. It's just not politics. It's the private sector. You want to really make improvements, let's take a look at the healthcare system right now. There's tremendous improvements out there. Right now, we can have our EKGs taken on the back of our telephone. That's the private sector. It's education of the consumer as to what is best for them. We have to get that out. But let's not just leave it to the government. Let's take a look at some of the tremendous innovations. CVS, Walgreens, Walmart, all of those are involved right now in lowering the cost of healthcare because they're setting up clinics, nurses right inside the store. Why do we have to have dialysis put up have everybody go to? Why don't we teach people, have a nurse come into the house and have it done and hold down costs? There are so many wonderful things come out in regards from the private sector that can lower the costs of healthcare tremendously, educate the public, and move this forward. It's just not government that's going to solve this problem. The private sector is going to have a tremendous interest, and they're going to accomplish a lot more, a lot faster than the government system.
You're not saying leave it entirely to the private sector,
Oh, absolutely
or
not.
are you? Is that what you're saying? Yeah.
Absolutely not. But you're all talking about just the government. And I'm saying absolutely not. I'm saying the government's got a place. We got to start looking at it on a bipartisan basis. But let's also start encouraging the government to take a look at the private sector and allow the private sector really to start innovation. Pharmaceutical companies are coming out with some tremendous drugs. I'm on several boards with small companies. C.R. Bard is one. Some of our innovations on some of our devices are so far out there that you guys are all going to be just excited about when they hit the market. They're going to solve a problem. And that's taking place all over America. I'm involved with 25 small healthcare companies. Every single one of them has got a product or a device that's going to improve the quality of health and save money in the future. That's the direction of healthcare that we have to also encourage.
Kathleen Sebelius, are we not adequately appreciating what's going on in the private sector?
Well, I think that there's no question there has been an explosion of private sector activity. Certainly devices and drugs, we have led the way in this country for decades, and that's going to continue hopefully into the future. It's a terrible time not to invest in more research because we know a lot more now about the human genome. We know a lot more about the possibility of cures, and it's I think, a very stupid policy of the United States government not to double down on research dollars. But having said that, technology is finally hitting healthcare. And that's a very good news. The kind of improvements that we've seen in other service industries across this country, an explosion of trying to figure out how to make it easier for people to access services, that's going on in healthcare. And I think in a way that really can lower costs and improve care at the same time, and that's very exciting, and that's going to be driven by the private sector.
You know, we have data now that we've never had before. Until June 1st, I ran a large healthcare system. We've never had the kind of information about outcomes and about who's working and who's not working that we have now, and that all came out of a huge investment in IT.
How well served are Americans by our healthcare system now? And this is a leading question because a number of you, we had a conversation earlier today, a number of you told me you're concerned that the poorest Americans, low-income Americans, are at risk of losing some of the Medicaid coverage that's out there now. How good a job is this country doing of serving everybody?
Well, let me answer that. If you have money or insurance, we have the best healthcare system in the world. If you don't have money or insurance, you are in a third world country so far as health. And that's one of the reasons I'm enthusiastic about the Affordable Care Act. I agree with my friend Tommy that it's not a perfect bill and we need to work to improve it. But the reality is, if you're poor, you don't use the system, or you delay until you can't stand it anymore, and then you run into the emergency room, get emergency care, then you leave and there's no continuity. So that's not good. So having insurance allows a change in behavior so that people will get preventive care, regular care, and early care. But one of the problems we have in this country is we have a great system. We have the best trained physicians and other health professionals. We have tremendous technology. I think it's been phenomenal. But that is absolutely out of your reach if you don't have insurance or if you're poor. And some of areas in the country, we have health statistics that are third world country statistics. Infant mortality, dental caries, deaths from stroke, et cetera. So we really are two countries in one.
And several of you were telling me a few hours ago that you're concerned that if the next administration is, if there's a Republican president and there's an unwinding of Medicaid services in Washington and around the country, that what Dr. Sullivan just described is going to get even worse.
Well, I would say that not only has Dr. Sullivan, I think, adequately described the kind of economic gap, but I would go a little further to say some of the people who pay a lot of money for medical care are still not getting the right care at the right time.
Yeah.
There are still procedures being done that shouldn't be done. There are still outcomes that just aren't the right outcomes, and they are well insured and well able to access the system. They're just not getting to the right person at the right time. So we have, I think, we have the best medical care in the world for some of the people some of the time. But not for a population at large, and certainly not for the poorest and the uninsured.
How secure?
I want to respond because you brought politics into this thing. Woe be us if a Republican is elected. Oh my Lord! If I look back,
I'm talking about if you were elected.
If I was elected, everything would be okay. But I'm not. I announced that last night, but nobody came up and didn't give me any money. But anyway, if you take a look at some of the great advancements that's been under a Republican administration, and it's been usually on a bipartisan basis. So don't tell me that because there's a Republican may get elected, and hopefully it will, that things are going to go to hell, because they're not. The healthcare system is moving in the right direction. Now what we have to do on a bipartisan basis is to be able to come together and refine the ACO and make it better. Medicaid, there's a good way, I used the block grants when I was governor to change the welfare system. If we start block granting some of these Medicaid programs in some of the states, you'd be surprised at the innovation that Republican governors would be able to come up with and improve it. I disagree with Lou in regards to the fact that the poor are not covered. It's not the poor. The poor and the rich are taken good care of. It's the individual that's a little bit above poverty, because the one that's really poor is usually on Medicaid or on some kind of government program. It's the poor bloke that's working 8 to 10 hours a day on minimum wages that doesn't have coverage, and that's the person that I am really worried about, and that is we need to take care of that, especially in rural Wisconsin. Rural Wisconsin has a lot of problems too, and it's just not there.
The ACA, though, the ACA is taking care of the working poor.
The working poor but also the real poor in America are usually taken care of. It's the people above that are not.
Right. But that's the Accountable Care Act. I mean, that's a so-called Obamacare. They're taking care of the working poor. That's the gap that was in the insurance system, is to take care of the working poor. If Tommy Thompson was governor again, I would give him a block grant in a minute. And I gave him some waivers, too.
Yes, you did. I had to fight like hell to get them, but you did.
I want to point out that I used to work for the governor. I was chancellor when he was governor. We got along great.
We did.
But I agree with Kathleen. I don't think the healthcare system is so fragmented that we can't say that everybody gets the best care.
That's true.
That pays the most, because it's so fragmented. That's not true in other countries. You look at the outcomes, they've just got a more integrated system, and we hope that technology and other kinds of changes will make the difference to give us a more seamless system. My only point about politics is that at every point in which we want to make the system seamless, someone's making money off the way in which the system is currently organized. So putting that seamless system together is extremely important. I just ran a healthcare system. The volumes are up, but the income is down. Not much, but it's coming down, because the payment systems are getting tighter, and the insurers are demanding more integration, and they're demanding better outcomes. So the value added parts are just beginning to change, and you're beginning to feel those changes. in this country. It's not going to be the same healthcare system
So
for the next president.
I want to close the loop, though, on this Medicaid question, coverage for low-income Americans. So you're saying to me that this is not at risk, that these individuals are covered and they're going to continue to be covered. Is that what I'm hearing you say?
I wouldn't say that because we've looked at, anyone that's looked at the Republican budgets knows that what they've done is they're block granting Medicaid, but they're not putting any increases in it. They're taking 70 million, I think, off the top, 700 million off the top, and then squeezing it down and then giving it to the governors. Frankly, the governors, no matter what party they're in, don't want it that way. They want it with real increases in it so that they can adjust to the changes, the economic changes in the country. But they're
Judy, what's not, I don't think, still well understood is that the most expensive population in Medicaid right now are older, frail elderly in nursing homes, older, poor people in nursing homes. Medicare doesn't pay for nursing homes. Once you get poor enough, Medicaid pays for nursing homes. That's about 40% of the budget in any state. So if you cut Medicaid right now and have the continued aging of the population, which we're going through, you have a real problem on your hands. There's no way to cut it and deliver the services to the people who need them.
I want to tell a story. Southerners do that, right? Arkansas, Helena, poor. Pretty good medical school, pretty good program of outreach to the people. Clinics in the Helena poor neighborhoods, poor communities. Nobody used them. They were there. Everything that policy could do had been done. The programs were there. People trained there. They were eager to help. They were friendly. Nobody used them.
Why not?
Well, the first answer was no transportation. Turned out that wasn't be a problem. Problem was that the people in those white coats didn't look like anybody that the folks in the neighborhoods would go to. And so even the grandmother of the woman that was running the program to get people in couldn't get her grandmother to go. There were issues other than transportation, subtle cultural issues. You don't go to the doctor till you get sick, right? That's just not being tough. All kinds of, and it's those things that we are not understanding about the healthcare. We're talking as though the system could be changed by policies, and certainly they have effect, and it would make a difference whether one party or the other party made the party. We have to go deeper to understand that. For example, how many of you got a inoculation for the flu this season? Wonderful. You are way above the national average. I've forgotten what it was. And people were not willing to do what you did. They read the same information. They decided that there was a danger in inoculations. All of the information in the world couldn't change their view. The whole proposition that if you knew what I knew as a physician or an expert, you would do what I would do is just not true. Okay? It's not partisan politics. It's not this group. It's not the other. It's that our health care is going to force all of us as individuals to face up to difficult trade-offs, even in our own behavior. Is it better, you're going to have to ask yourself, for you to get an inoculation because you're going to protect the whole community? Or is it better for you to protect yourself because you're afraid that there's something in this inoculation that's going to injure you? That's a personal decision. It's a difficult one. It's a trade-off.
So, yeah, Dr.
I
Sal.
would like to just extend on Dave's comments. As you know, 37% of our population is non-white. You look at our health professions, you find that the maximum, whether you have in any health profession, of people who are non-white is 15%. 4% of dentists. We have a Hispanic population that's 15%, a black population that's 12%. And one of the things is that when you say that people don't see themselves in the health system, that's one of the issues.
Literally don't see themselves.
Exactly. And this has been studied. Dr. Komarami in San Francisco in 1996 pointed out that black physicians or Latino physicians were 3 to 5 times more likely to settle in the barrio or the ghetto. But not only that, their practices were different. They had higher percentages of patients who were uninsured, higher percentages on Medicaid, so they were delivering care to a different kind of population. Now, by 2042, there's no longer going to be a majority population in the US, according to the Census Bureau. One of the areas that we are not addressing is getting more diversity among our nation's health professionals, as well as increasing the cultural competency of our health professionals. Because I agree with Dave and my other colleagues here, health is the sum of all kinds of things. How well educated are you? What kind of house or what neighborhood do you live in? Right. All those things affect you. So we need to do more than simply fix the insurance system if we're going to improve the healthcare system. That requires a lot of things, including looking at our health professionals, seeing that they become more diverse.
You're saying people are going to feel more comfortable about going to the doctor, going to the dentist if they're working with, if they're going to a professional who
Exactly.
If you want to see diversity in the healthcare system, come to Miami, because we've overcome a lot of that in the training of health professionals that stay in the community and treat the population. But the whole point about you have to understand the populations you're dealing with and deal sensitively with those populations. Flu shots are up to 80%, I think now, David, but when they were first introduced and we exempted, we told the Medicare population we would pay for it, the Medicare population did not pick up the flu shots. And it's an interesting story because we went out to find out, like most government employees, we went and ran a campaign and we got about 15% to take us up on it. Mm-hmm. And so we went out and actually talked to people. We interviewed people. And here's what they said. They said, yes, Medicare would cover it, but their deductible started the month they were supposed to get the flu shots. And they weren't willing to spend an out-of-pocket amount because they saved the deductible for something important like an operation. So when we excluded the deductible from the flu shots, then we got huge take-ups. Well, the elderly population born during the Depression has a different attitude about deductibles than other populations, and you have to understand the population you're dealing with if you want the health system to work for them. And it's poor people, elderly, people from different ethnic groups. All of this requires a great sensitivity if you're actually going to deliver a high level of health care.
Governor Thompson, and then I want to come back
you
to
know what I
cost.
really would like to see? I'd like to see, money is a great motivating factor. You know that? Why don't we put some real money into the commission corps that all of us run? And make sure that more young people go into the commission corps and pay them well and allow them to go into the real urban areas, the rural areas, and so on and so forth. Why don't we put some more money into the medical schools and allow young doctors, young men and women, to be able to go into the hard-to-serve areas and pay them for them and pay their scholarship? You would be amazed at how much we could start changing it. Do the same thing for minorities. Be able to get more of a diversity into the urban areas and use the budgets of the state and federal government to really encourage young men and women to go and practice and be able to pay for their education if they spend 5 years in the city of Milwaukee or the city of New York or up in rural Wisconsin or rural Mississippi and Arkansas, down in the Delta where they really need help. If you want to look at a really hard to serve area, it's the Delta area in our southern states. And that's why I think if you use money wisely, you could really start changing the direction and bringing more young men and women into the field and really starting to take care of hard-pressed areas.
Kathleen
Well, it's
Sebelius.
one of the reasons I think you're absolutely right, and it's the National Health Service Corps. It's kind of the Peace Corps for health workers, and it was tripled over the last 3 years, 3 times as many. We could use 10 times as many.
Absolutely.
And it really is a trade-off. If you go serve in an underserved area, part or all of your medical debt is paid. And it's doctors and nurse practitioners and dentists and mental health professionals. But the other thing that's found is a lot of times when those professionals are located in an underserved area, they stay and they work there. And so a long-term commitment is often made by these young people. I think we have a huge problem in just overall debt, student debt overall, but medical student debt is huge. And it, again, is an issue when young docs are looking at, should I be a specialist or should I be a general practitioner? If you can make 4 times as much as a specialist and you're carrying the same debt load, there's a real financial incentive to move in one direction. So I think we've got to look at how many graduate medical slots we have, where they are, how many are directed, but also the kind of debt that we should be helping people get rid of much faster or not accumulating in the first place.
Do we worry too much about the high cost of health care? Is it just something, it's a given and we can't do much about it?
Well, we should worry about it because we can't afford it as individuals, as employers, as governments. And again, we are spending in the country an astronomical amount of money for mediocre results. The bang for the buck isn't there, and I think we need to pay a lot more attention to that.
But go back to the Accountable Care Act. The importance of the Accountable Care Act was that you have to get everybody covered before you can take on the cost structure. And the reason for that is otherwise you're just cost shifting all over the place.
Yeah.
I went to Detroit to speak to a small business group. And a woman got up and she said, you know, we don't need universal coverage. We don't need the government to give us any additional health insurance. She said, all of my workers are covered. She said, they have very good health insurance. And I said, you're a model for small businesses in this country. She said, no, I don't provide it. All of them have spouses who work in the auto industry. I mean, so the cost of an American car includes that cost shifting. So we couldn't get our arms, we could do a lot of things, but getting your arms around the cost of health care is easier if everybody has insurance and all that cost shifting isn't going on.
Is that something you disagree with, Governor Thompson, that you need to cover everybody before you can really get the cost down?
I'm not going to go that far, but there certainly is an opportunity to expand the coverage. And there's tremendous ways in which we can hold down the cost, and cost is important. You don't need to see a doctor at every time you go. Nurse practitioners can, Donna and I have talked about this many times. There's so many things physician's assistants, nurse practitioners could do to hold down the cost, and we're not doing that. And maybe what we need to do is we need to encourage more nurse practitioners, more family docs, more internists than we are. Maybe we have enough plastic surgeons. You can look at my face and say probably not enough. But maybe we should really start doing what is smart, getting people that are really going to start doing it. I disagree with Kathleen Sebelius saying we got a mediocre system. We have a diversity system. We have some very good, some very poor, but I bet everybody in here likes their healthcare system. And I bet all of you get good healthcare system. And I think you probably do, maybe you don't, but I really sincerely believe that we have the makings of a great healthcare system. We have to do some smart things that we can do. We need to expand service, and we can do that. But I'm not sure that the total enrollment of everybody is the right thing, and I don't know if we can afford it.
How many of you are satisfied with your health care coverage right now?
How many of you are satisfied with your doctors? See, that's the differences between the healthcare system and the doctors.
Judy, what I say, we have a distribution problem.
Yeah,
As I say, if you have money or insurance, you can get care really as good as anywhere on earth and better than most places. If you don't have money or insurance, then you're a third world country. In the nation's capital, northeastern Washington, infant mortality rates are like third world country rates. This is our nation's capital, and we have pockets of that all over the country. So this is not in some far off place. This is the result of poverty, having a system that's not welcoming to poor people. The first thing that happens, you go to a hospital doctor's office, show me your insurance card. If you don't have it, then you're out of luck. So having the best healthcare system in the world doesn't mean a darn thing to you under those circumstances. So we have to change that.
So, Dave Mathews, let me start with you. What do we need to do? You all have been talking about prescriptions all along, and how do we need to make it better? What are some concrete things that you would do if you were back in office and you could wave whatever the proverbial magic wand and see some things change to make health care available and accessible to all Americans? High quality health care, but what would it look like?
I think the real challenge in our government right now is the interface between the government and the formal institutions and the informal organizations, communities, neighborhoods, civic groups, civic organizations, churches. Those are part of a system, but they're not well aligned. It's like watching gears that don't mesh. Healthcare is so vast, so it goes from the individual to the family to the community. The government can and should touch some parts of that, but other parts it cannot. Probably the greatest curative medicine we have is the compassion of another human being. The government can care for you with aid and assistance and doctors, but only another human being can care about you. And how the government relates to the other parts of our society, I think, is the key question. We have a lot of local initiatives, a lot of things that people are doing civically to solve problems, but the way the government relates to those is problematic. And so that's where I would concentrate.
And you're talking about organizations like institutions such as what?
Well, I'm talking about neighborhood associations, I'm talking about churches, I'm talking about the natural places where people go and congregate and live. I'd talk about families, I'd talk about any of the, and you all belong to them, you know what they are. Those organizations are in fact part of this system, and we can't move the government part of it without taking into consequence the others. Like pushing on a piece of Jell-O. If you push on this end, something's going to happen on the other.
Tommy Thompson, what would you do? I mean, you've already talked a little bit about it, but what would you change if you were back in? I mean, you've said several times it's not just the government, it's a lot more. That's what David Mathews is saying.
Number one, you got to take a look at what are the cost drivers. Cost drivers are 75% of the cost of healthcare go for chronic illnesses. I put out a tremendous educational program across America in regards to obesity, tobacco cessation, and diabetes. Diabetes is way out of control. We got to do something. A lot of that is in obesity. We got to put our emphasis on that. Number three, I really sincerely think we got a great healthcare system. I disagree with my friend Dave, and the guy who says it's a poor healthcare system. I bet there isn't any of you that would go to Canada to get your operation or go to England. You'd come here. People from all over the world come here. That indicates that people want to come because of our healthcare system. What we got to do is we got to level it off a little bit more so that more people have access to it and we're able to improve it. We spend way too much money in mammoth hospitals. Hospitals are going to go by the wayside. Clinics, surgical clinics across America are going to be taking the place. Big box hospitals are on their way out, and we spend too much money putting money in there, and we need to put them more into surgical centers. We need to do something about diabetes. We need to do something about tobacco cessation, chronic illnesses. We have to start allowing innovation in America. We got to change the FDA so that drugs are able to get to market much faster. It's ridiculous that it takes 12 years and $1.2 billion. Some people say $2 billion, some people say 20 years. Put in 4 phases. Put in phase 1 for safety, phase 2 for efficacy, phase 3 for trial, and then put it out there and allow the people, and then have a 4th phase to come back and look at it. You would save money on drug development, drive down the cost, and make more people. Number 5, why don't you allow people who are dying be able to have access to the medicines? About 10 states now, if you have it, use it. But FDA will not allow it, Congress will not allow it. I had three brothers that died from pancreatic cancer in the last 3 years. Every single one of them would have loved to have had the opportunity to take a medicine. What's wrong with it? If they're going to die, and they want to be able to be helpful, why don't we allow some experimental drugs to be taken by individuals like that? There are so many wonderful innovations out there that could drive down costs and make healthcare simpler and better. Let's use, as Donna Shalala and I talk about, nurse assistants, physician's assistants, and you could save a lot of costs as far as healthcare in America and make more people access. The telephone is going to be the new doctor. You're going to be able to call your doctor when you need somebody. They're going to give you a prescription. You're going to take it. You're going to take your EKG. It's going to be using your examination and be sent into your doctor, save money and save time. What's wrong with that? Those are the kind of things we have to do and look at to improve our healthcare system and make it better.
Dr. Sullivan, are those some of
You
the
should have
prescriptions?
voted for me for president. I would add
It's not too late to get in.
Every day there's a new one.
They haven't closed down the primaries yet. You can still get in. Dr. Sullivan, are those the kinds of things you would do? And I don't want to, beat a dead horse, but to come, I mean, you heard Governor...
No, I agree with that, but
Scott Walker.
basically, there are a number of other things. Tommy talked about the private sector. One of the things that's happening in the private sector that's not really getting much attention is a lot of companies are saving costs. Johnson & Johnson, some 8 or 9 years ago, implemented a wellness program with their employees with incentives, and they showed that they were saving $3 million a year, the company, with reduced costs. Pitney Bowes and other companies, the International Harvester Company, by reducing worker injuries, et cetera. So we need to do a lot more of that. But I agree with Dave here, we need to take medicine and the health system to where people are. One of the problems people have with many of our institutions is they don't trust them. So they don't trust hospitals, they're fearful that they will not get the right treatment, et cetera. So use the institutions that they know and that they trust, whether they're clinics in churches or community health centers, et cetera. But we need to have our citizens become much more proactive in taking responsibility for managing their own health care. That's why we need to improve health literacy in the country.
And you're saying do that, that's not the government's job. You're saying that's something that just needs to happen.
The government has a role, but no, this is everybody's responsibility. The problem is it's not the private sector or the government, it's both. And so we need to marshal all of the resources here.
Kathleen Sullivan, what would it look like? I mean, if you were in there and you were the
I keep
president,
getting called different names.
what's it going to take?
Well, I think a lot of what Tommy Thompson said is absolutely on point, and a lot of that is starting. It's moving slowly. We've got to accelerate the pace. And what I find really exciting is I think healthcare was really stuck in the 20th century. Some would even say maybe in the 19th century for a long time. If you went into a doctor's office 5 years ago, you were given the clipboard as if you fell off the face of the moon. You filled out by memory what medications you took. There was no way of verifying it. Information wasn't exchanged. If you were a complicated patient, a diabetic who needed foot care and eye care and general care, somebody to monitor your blood pressure, it was up to you to coordinate that care, to get to the right person, to not let it fall through the cracks. That system is really changing. And I think that is good news. And technology will add a lot of pieces to that puzzle. Technology, I think, can help re-empower the primary care doctor to be the care coordinator, to actually monitor what's going on, to make sure that you don't run 15 of the same tests, that if you had an EKG run by this specialist, it gets sent automatically and becomes part of your chart. That just wasn't happening a few years ago.
That's true.
So you're saying these things are already happening?
Well,
and-
they're not happening fast enough, and they're certainly not happening to scale, but they're starting. One of the most, I think, interesting portions of the Affordable Care Act, which is not well talked about, is that for the first time, the Centers for Medicare and Medicaid Services, first of all, has a stream of research money. They've never had that before. And they're testing protocols for how to improve health care and at a minimum not raise costs, but ideally lower costs. What works? What's out there? Everything from accountable care organizations to paying for bundled care to helping make sure patients don't come back into the hospital too soon, that there's follow-up care. Some of those experiments are showing very promising results, but the most important thing is the law gives CMS the authority to put those in scale overnight, administratively. They don't go back and ask for permission from Congress.
Right.
This can move a lot faster than it's ever done before, and I think that's very good news.
I think one of the things we've learned over the years is economic incentives can drive change. And the new secretary would have to identify those economic incentives that can drive change. Sometimes there's simple things like, hey, we won't pay if someone got an infection and was readmitted to a hospital. You can't imagine the discussions on hospital board meetings about losing money if they're not careful about patient safety. And the kinds of things the Center for Medicare and Medicaid Services are doing, those kind of experimental things are key. But if we look at history, we extended life in this country with 3 or 4 things: sanitation, clean air, building codes, and vaccines. And I think that we know that we could drive down costs if we got Americans to exercise, to eat right, and not to smoke.
Yeah.
And if we would focus on some of the low tech with real investments, as opposed to just focusing on the high tech, meanwhile change the payment systems with economic incentives, that all of that would go a long way towards improving outcomes, making the system much more integrated and seamless, and we would have extraordinary outcomes in this country.
Dave Mathews.
One last story. World War II, meat shortage. We were trying to get people to eat meat that they didn't like. Cow's tongue, hog intestines. They're popular in the South, by the way, but no, haven't caught on. And a guy named Kurt Lewin went around to see if he could get people to eat unpopular courses of meat, and he tried first just moral suasion. We're at the war, people are making sacrifices, you should eat this stuff, okay? And he got about that much change in behavior. Then he did the thing that we do now. He did education. He had information about the nutritional value of the foods. He had chefs come in to show you how to cook the food so that it was more palatable. And he measured the change in behavior. And it was a little bit more. And then he got people together to make a decision collectively about what the community should do. Should we, all pitch in and eat this stuff? Or should we feed our families something they could eat?
Catfish.
And that's right, catfish. And lo and behold, he found enormous changes. Right? There was a case study recently in Alabama on breast cancer. Rural community, high rates of breast cancer. One of the obvious reasons, nobody was getting mammograms, all right? So they went in and they did forums on what are we going to do about the high rates of. And they got exactly the same results that Kurt Lewin got in the war years. They got big exchanges, big changes in health. Plus they got some interesting biracial cooperation because breast cancer is an equal opportunity disease, right? Okay. So we have learned, we know a lot about communicating to others that will enable some changes in the behaviors we have to change. And we've got to go beyond just saying don't do that. We've got to go beyond just simply good information. We've got to go to people making collective decisions in their families, in their neighborhoods about what they can do. You all have come here to learn about what's going on in the health system and what people like us are going to do. But I think it misses the most important question of all. And that is, what are you going to do? What are you going to do to make for a better health care system? in the United States. Your initial reaction is, oh, I'm just one person. I can't do anything. You are absolutely wrong. You're part of families, you're part of neighborhoods, you're part of organizations. The crucial question here is, what are we going to do personally?
Inspirational note. Before I take questions from all of you, I just want to ask each of you, what's the one piece of advice you would give the next Secretary of Health and Human Services? Dr.
Develop a
Sullivan.
more vigorous health promotion, disease prevention program. The 20th century, in my view, was the time of scientific advances. We want them to continue. But we neglected improving health behavior. If we are successful in improving health behavior, as we have in a few areas, such as decreasing tobacco use, we will see an enormous improvement in health of our citizens and also a dramatic reduction in healthcare costs. That's why we need to emphasize health literacy in our population to a much greater degree than we have thus far.
Donna Shalala.
I think what I just said, to focus on some prevention up front and to organize the private sector and the country to do those three things. And then I would use economic incentives. I would streamline the whole system so that innovation could come in, and but to do that in a bipartisan manner.
Be bold. You have an opportunity like you've never had before. The healthcare system has got to be changed. It can be built upon in the ACO. You have tremendous opportunities. Sit down with the leadership of both political parties. Invite them over to the Humphrey Building and sit down and have coffee with them and talk to them about changes. 3, do something about chronic illnesses in America, which is 75% of the cost. 4th, start talking about death in America, because we're all going to die, but 28% of the cost of Medicare is in the last 6 months of a person's life. And what happens? A grandson and granddaughter come home after they haven't talked to grandma in 8 months and feel sorry, and they demand that grandma has every bit of care, and all grandma wants to do is go home and retire and go to sleep. And we force poor people and elderly people to take more drugs and so on and so forth, driving up the cost of Medicare and not improving their quality of life one bit. There's so much that can be done. Let's do it. Let's do it together on a bipartisan basis, and let's look for America to be, once again, the best healthcare system in the world.
Kathleen Sebelius.
Stay away from websites. Just saying.
And David Mathews.
Not a website answer. Look, we need a communication between the people of the United States and the government of the United States that's honest. There is nothing that you can think of that you can do about anything that's not going to cost you something. That's not a partisan issue. That's life. For every action, there is an equal and opposite reaction. Our political rhetoric and the way we talk to our government suggests that that's not true, that we live in a universe where things that go up don't come down. They do. And I think we need a real honest conversation with people about the costs and consequences of the tough choices we're going to have to make. The technology can help us, more efficient administrations can help us, better training of professionals can help us, better drugs can help us, but ultimately we're going to have to help ourselves. And to do that, we've got to face up to tough choices.
On that note, let's take some questions. A lot of hands are up. We're going to bring a microphone to you. Let's start with this gentleman right here.
Thank you very. Does it work? Thank you very much. Thanks to the panel. It was exciting. It was fantastic. So thank you all very much. So Governor Sebelius talked about electronic medical records. How fast
Do you mind
they've grown.
standing while you're talking? It would just help.
Governor Sebelius talked about the rise in electronic medical records. Governor Thompson talked about the new electronic doctors that you'll be able to be your own physician, empower the consumer. All that stuff's transmitted over the internet. So I guess I have two questions. Should we as consumers be concerned or accept the fact that 5 or 10 years from now, our medical records are not private anymore, or worse yet, 15 seconds after you transfer your blood pressure, you're gonna get a pop-up ad from Google on a blood pressure machine? And, or worse, is our healthcare system going to become as vulnerable as our electronic grid and our financial systems to hacking? Two questions.
Well, I don't think there's any question on the latter that the hacking issue is one that is dealt with every day. And there are breaches every day, and security is reinforced, but that is a concern regardless of where that technology is, whether it's your financial information or your health information. I do think extra care has to be taken to protect the privacy of medical records. There are lots of laws in place that try to do that, and I don't think that necessarily electronic platforms are more vulnerable to privacy issues than paper platforms. In some ways, paper platforms are a lot scarier because people can come in and just take your files, and they're carted around in boxes. And I think anybody who went through Hurricane Katrina could tell you that paper files were scattered throughout that town. So there are protections that electronic records can have, but privacy concerns are huge, and I think need to be paid very careful attention to. And having your medical records in your employer's hand, for instance, or your banker's hand, can be very precarious, because it could mean job loss, it could mean that you won't get a loan for your house, it could mean any number of things. And I think medical records are among the most sensitive and vulnerable records that anybody has.
I agree totally with Kathleen. But the truth of the matter is, I find cybersecurity something that we're not taking it seriously enough. We have to do something about it. But I once raised a question. I says, now, why are you against electronic medical record? Well, because somebody can peek in and get it. And I says, those manila folders in the doctor's office and clinic, you don't think that people are looking at those? I mean, let's face it, the truth of the matter is they're much safer and more secure than those manila files in the dentist's office, the doctor's office, and so on and so forth. We just got to be overly vigilant and try and do everything we can to protect the privacy of the patient.
Okay, there's a hand right there, that gentleman, and if you could just make the question brief, we're going to try to get to as many people.
You've talked a lot about behavior change, and you've talked a lot about technology. I spent my career as a technology entrepreneur in healthcare, and one of the challenges has been the difficulty of taking a product to market. In many, many cases, there's no market for those kinds of products. And part of the reason for that is, and a lot of the new technology right now in particular, some helps providers, but a lot of it is being directed towards consumers. Why, and Medicare ultimately ends up being the insurer of all those chronically ill patients who don't change their behavior. Is there a way for Medicare to actually pay for behavior change, not just to providers, but to community groups and others who have expertise in developing the methods necessary to change behavior?
Actually, Medicare now has an innovation fund that can help all of that. And but let me tell you, as someone that was a provider, deep down inside, I don't believe, though IT has made me start to change my mind, that technology is going to save me costs. Because all of my experience with medical devices with new technology is that it increases my costs, not decreases my costs, whether it's the new proton or whatever it is. And unless reimbursement catches up with some of it, it's very difficult for providers. But in terms of innovation, there actually is an innovation fund that's starting to invest in these kinds of changes.
Well, I think I would just say the other issue to the technology question is a lot of analytics are now underway. What is it that causes change? How do you, what's the right point to get to a chronically ill person to prevent the next hospitalization? Those kinds of issues. And so I think there will be payment streams that follow those results in a way that haven't before, and I think that area is really starting to be robustly developed.
Okay, way over here, the gentleman with your hand up right there. There you go. Just, if you would, keep your question brief, and we'll try to get to a few other people.
So I feel like there's an elephant in the room here because we're celebrating the 50th anniversary of Medicare and Medicaid, and we're talking about mediocre health care, and then you look at all the countries around the world who are doing better than us, and they have a single-payer system. So why don't we have that, and what could we do to get there?
Well, I thought there's a lot of argument back and forth for that, but quite honestly, you've seen how difficult it has been to get to where we are now with the Affordable Care Act. If you want to have another 10 or 15 years really of argument, then push that. I'm not for that. I'm for taking what we have now, making it work as best we can, and I think we can do a lot because the public can't wait. I think there's a lot of merit to that, but you could see with the healthcare system trying to change it is such a monumental task that we just start a fight all over again. So I think let's really try and make this law work.
Yes. Okay, back here. Thank you. Microphone.
Thank you for your tireless, endless work. Everything you say comes together in a way where we don't have to invent the wheel and we can save costs. It's called the Community Mental Health Act and the Health Care Act. Mass General Chelsea Health Center was started in the early 70s. We all did outreach, home visits. We worked with the with the pediatrician, the internist, the schools, the police. We had abuse neglect teams that was federally funded, state funded, and private Mass General nonprofit. We did all the work with the courts. It was all preventive. We had Vietnamese outreach workers. We had Spanish outreach workers. It still goes on. It is a great prototype. So how do you get the government or the human services to get the courts to institute what that law was that hasn't been instituted fully? That's part one. But two is,
No, we need to make it one. I'm sorry. We're going to have to make it one. Who wants to tackle that?
Kathleen, you want to tackle it?
Well, I'm not quite sure what the question is. In terms of, I hear what you're saying. An integrated system does work, and it's in place in pockets. I'm not sure that can be driven necessarily by the federal government. At the state and local level, people need to come together and say, this is the system that works, because clearly health outcomes are impacted by the air we breathe, the food we eat, where we play, where we work, and interfaces with the criminal justice system, as well as the healthcare providers. So I think that's really a local situation, not necessarily something that the feds can solve.
Okay, we've got 5 minutes left. We're going to try to get a few more questions in. Here we go.
Hi, my name is Candy Lewis, and I just want to thank all of you for being here today. I mean, you were just great. The one most important thing that I'd like to say is my father had a great expression. He said, when you're healthy, you're wealthy. And I think, Dr. Sullivan, you mentioned that. And the main thing that a lot of you had said today is the education. We've got to get the education out to the general public, because that's what's going to make the people healthier. Going and popping pills every day is not the answer.
Thank you. Okay, there was a hand right here. Yes. Somebody right there. Yes, that gentleman, the white.
Thank you. My name is John Flood, and I'm from Florida. And I want to thank you all personally for what your contribution has been during your service.
Thank you.
I am a... One thing I didn't hear about is the VA healthcare. I am a Vietnam vet, and I get all my care through the VA in Florida, and it's been outstanding. They've kept me alive for 10 years, but I heard nothing about the veterans' health care.
Well, the VA system is a classic socialist system. You walk in, you get all your services, and you get your drugs. And we just are not in a position in this country to be able to, the answer to the single-payer system, to be able to expand that system to everyone in the country. It is costly. to expand it. I'm certain that a number of academics have looked at that, but thank you for your service. And those who have served deserve a first-class system, but it's a highly integrated. The VA system uses nurses better than any other system that we have in this country. And, but they also have low-cost drugs. They negotiate low-cost drugs, and it's a very integrated system. But it's a classic socialist system.
This gentleman in the blue shirt, and then we'll come over here.
Hi, thank you also for your service. My question is, in the Amazon, eBay, TripAdvisor world that we all live in, when do we get cost and quality transparency?
I can't understand you.
Cost and quality transparency.
Okay.
We're moving there.
There, information right now is on the website, which has never been there before. So you can go to hhs.gov and you can do hospital compare and look at different procedures and different costs. You can put in a zip code and find out infection rates. You can go to doctor compare and find the same information. Now again, this is just government pay, so Medicare payments for those doctors, but who's doing what kind of procedures they're doing, how much they're collecting. You can do it with nursing home compare. You can look at comparative data in a way that wasn't there 3 or 4 years ago, and it's getting better as we go along. We need to get a lot further in terms of what price transparency is, what things really cost, and who's paying for those costs. But I think there's more information now than certainly there was a few years ago, and consumer demand should press on and make it clear that that is unacceptable to have it opaque, that you need more information and more ways to actually look and compare systems. But it's coming.
One more question, this woman right here, and then we're going to wrap it up.
Unplug yourself.
My name's Marilyn Sussman.
And I want to thank Secretary Thompson, Governor Thompson, as he has to go catch a plane. Thank you. Appreciate it. Thank you. Okay,
Run,
go ahead.
Tommy, run.
You've not talked at all
Don't
about...
collect your campaign donations, just go out the door.
You've not talked at all about mental health issues, prevalence, treatment, distribution, and in addition to being comorbid...
Sorry, I'm not here.
In addition to being comorbid with physical illness, mental health in and of itself is a major problem and a major drain on resources. So would you address that, please?
Well, I don't think there's a lot of question that the mental health parity bill sets a framework which has never been there before, which says for the first time it's all about health. We shouldn't have a division that says you can only have so many visits to a mental health provider and different number of visits for a physical health provider. That's a long way from integrating the system and recognizing that, particularly for chronically ill, there are huge mental health issues that go along with illness and sickness. I talked to a wonderful doctor here in the Ideas Fest who's a cardiologist who's working now with a company to deal with how you intervene when somebody leaves the hospital after a heart attack around mental health issues, knowing that if they are depressed, which a lot of people are, they might not follow the best advice. They may not take their meds, they may not, and put themselves in a more vulnerable physical position, but also increase that capacity. So I think there's a growing recognition that this is all about health. We have to look at this as a seamless system. We have to have a payment system that doesn't differentiate. But more importantly, and I think some of the most successful models are incorporating mental health professionals right with primary care docs, not getting rid of the stigma that says you're somehow should go over
Louis,
here.
that's an area where we have a shortage of providers in mental health, and the VA is a place where they've just not been able to hire enough mental health providers because of the lack of a pool of mental health providers.
Great questions. Let's give a hand to these amazing Secretary Sebelius, Donna Shalala, Lou Sullivan, Dave Mathews. Thank you all. Appreciate it.